Alright, here we go. It's GIGU day, and it's the winter 2021. It's week 6. It's part 1 of 2. And here we go. Stomach lining conditions is where we left off, and I'm going to go on a little rant here. This is the biggest mess I've ever seen in all of my 5 classes. I teach 5 different lecture classes, and this is by far the biggest mess. Even worse, I think, than embryology. Embryology is pretty close, but it's just a mess. So the experts back in 1994, the GI docs, the experts, the leaders of the field, tried to get together to make a classification system for people with chronic stomach upset, namely something called the gastropathies. And this is, chronic, meaning it goes on and on and on and on. And so the meeting place was in Sydney, Australia, and it got named the Sydney Classification Systems. Well, they updated it in 1994. They've been trying to do this since the 80s. And they did a pretty good job, not perfect job of it, but a pretty good job. But unfortunately, the texts, the Rubins and Robbins, aren't very good at following this system, and it's very, very frustrating for me putting this lecture together from scratch. And hopefully won't be frustrating to you because you know what I'm going to test you on, but I worry about boards. So let's meet the chronic gastropathies is a better word for this. It can also be called chronic gastritises, but that's not the greatest word because itis means inflammation, and some of these there's no inflammation. It's just from a flat out, like if you drink antifreeze, you rip a hole in your stomach. Has nothing to do with inflammation, so that's really not the greatest word. I wish they would all call it chronic gastropathies. But this lecture was put together via this updated Sydney classification system. And here we go. So the chronic gastritis or chronic gastropathy, it is more chronic than real acute gastropathy. That example of drinking antifreeze would give you an acute gastritis, or would give you acute gastropathy. But acute gastritis is acute infection, like a lymphocyte heavy infection, and you get something like that. Those usually go away, but you never see the GI doc. So bottom line, these chronic gastropathies are way more common than these acute little stomach upsets. And they're a big problem. 50% of the world's population is affected by this condition to one degree or another. That's right, 50% of the world's population has this. Sometimes you can be completely asymptomatic and have no symptoms, yet you have a wicked, let's say an HP infection going on, which can ultimately increase the risk of stomach cancer if nothing's done about it. Why do we care about these gastropathies? Well, just because of that. If untreated, they can lead to not only cancer, stomach cancers, but PUD, peptic ulcer disease, which we've talked about a lot, and polyps, and GERD. They could have added, let me see if my markers work here. GERD, gastroesophageal reflux disease, could definitely be added to this, because we'll see that many of these gastropathies, they cause a huge increase in the secretion of acid. All right, classification system. I'm going on my rant. Let's just leave it at it's a terrible, terrible mess. Part of the reason that it's such a mess is because GI docs, gastrointestinal specialists, write books about it, and they have an endoscopic kind of view of things. So that's how they classify it. Yet histologists and pathologists, they see these slides from the result of the endoscopy, and they write books, and they classify it a different way based on their view of it. So it's just a terrible mess. All right, so the way I'm going to classify these, we'll call them the chronic gastritises, is via the updated Sydney system. All right, and we'll get into this, but basically there's just 3 types of chronic stomach upset, chronic gastritis. It's non-atrophic gastritis, atrophic gastritis, and special forms of gastritis. And we will get into each of these. So the updated Sydney classification systems, there they are. There's the 3 main categories. Again, non-atrophic gastritis, atrophic gastritis, and special forms of gastritis. The non-atrophic gastritis is, let's start with that story. So that's the first classification. And what do you think that means, non-atrophic? Well, non means no, and atrophy is atrophic, stomach. So these patients don't have atrophy of the stomach, and it's not the stomach per se, although sometimes you can see a visual atrophy, a visual through an endoscopic view, atrophy of the stomach. But most of the time it's a microscopic atrophy or non-atrophy of the stomach glands is what that really means. This one has no subcategories, unlike atrophic gastritis, which we'll talk about next. But absolutely, remember I promised you this slide coming up since second quarter because you thought there were a lot of A.k.a.s in a mess for embryology. You ready? Here it comes. Drum roll. Oh my goodness. These are all major pathology books and GI books, gastrointestinal pathology books, and Rubins and Robbins, and it is just a gigantic mess. See, now if any authors ever listen to this video, you guys need to get on the same page and choose one and maybe two A.k.a.s. But if you go into the research and try to research this, it's absolute mess. So non-atrophic gastritis, some A.k.a.s for this. So Robbins calls it H. pylori associated gastritis. I'm going to tell you why that's an absolutely ridiculous A.k.a. for it. And yep, then so Robbins likes to call all this stuff HP stuff. Rubin's the same. Then there's other ones. Acute HP infection. Notice HP is in a lot of these things because HP is a cause of this. But okay, I'm going to spill the beans. HP is a cause of this, but HP is also a cause of atrophic gastritis. So it's a terrible AKA because HP causes both non-atrophic and causes atrophic gastritis. So it's absolutely, I don't want to say stupid, but come on, guys. Superficial gastritis. So then we got the antral word coming in here because this gastritis affects the antral region of the stomach only, where the G cells are and where the pyloric glands are. So antral gastritis, diffuse antral gastritis, chronic antral gastritis, antral predominant gastritis, non-atrophic antral predominant gastritis. Get the idea there? So key words to look for is H. pyloric associated gastritis, something with antral in it, and then type B gastritis. B stands for bug, H. pylori, but that's not great either because, as I said, atrophic gastritis can be caused by chronic HP infection. But look for these key words, antral, H. pylori, non-atrophic, and type B. So make sure you can figure that out if I throw something up there. You don't have to memorize them exactly, but you should be able to pick them out. All right, some more shaming. I already kind of let the cat out of the bag. So why is it so ridiculous to try to call something HP gastritis? Well, HP causes both atrophic gastritis and non-atrophic gastritis. So it's just Robbins and Rubins need to get rid of that AKA. That's all I can say. Shame. Shame if I had my little, well, I guess they didn't have any bells or anything. They thirst through tomatoes and stuff. Game of Thrones, if you have no idea what I'm talking about, watch Game of Thrones and you'll understand. Okay, so finally, what the heck is non-atrophic gastritis? It's a condition which causes chronic inflammation, but it only shows up in the antral region of the stomach. So the fundus, the anatomical fundus and body and cardiac region are spared. But when the doc goes down there with a scope, the distal part of the stomach, which is the antral region, or the pyloric antral region, some people call it, it's all red, and because it's inflamed. So therefore, and this type of inflammation, it's caused by an HP infection. And so HP causes an inflammation as it gets into the mucosal layer. But it's not a damaging infection. It's more of a stimulating and irritating infection. So you're not going to find any stomach atrophy associated with. It's not going to destroy the pyloric glands or the G cells or anything like that. In fact, it might cause hypertrophy of some glands, which we'll see in a second. What is the cause? This little bug right here. That's H. pylori. It's a bacteria. And it, for whatever reason, it almost always starts in the antral region. And in some people who are more sensitive, it causes an inflammation and you get pain from this, chronic stomach pain. Many, many years go by, a couple decades go by, and this bug might take over the entire stomach. And if it takes over the entire stomach, it can do damage. It does more damage in the fundic region of the stomach. And there you get, that's one of the atrophic gastritis is when it takes over the entire stomach. But for right now, it's just in the antral region of the stomach. It is the most common form of acute and chronic gastritis. Again, this, if you have a stomach upset and it's going on for more than 3 months, you can't shake it, most likely it's an HP infection. Or you could say, most likely you have nonatrophic gastritis. Got it? Patient symptoms where their stomach's upset. So we talked in depth about dyspepsia. And the dyspepsia could be severe. I mean, you could have to even go to the ER. You're not feeling so good. And then, on top of the dyspepsia, you might be throwing up, or spitting up, semi-throwing up blood. You might see some blood come out. So that's hematemesis. If you have a significant amount of blood in your stomach, you're going to throw it up because that's very nauseating and irritative to the stomach. It needs to get out and you'll throw it up. Or if you have an ulcer in the duodenum, you might have melena, so your bowel movement or your stool might be black and tarry looking. So you have signs of bleeding. And then you may have GERD going on as well, which is our classic burning of the sternum and the manubrium. And then rarely still we have to mention some people don't have any signs until it goes into the chronic phase and destroys the stomach. What's the epidemiology for this? So HP is very common, especially if you're not treated. So in some studies, people over 70, 100% of them are infected with HP. In a well-done study by the Veterans Affairs Council, 2015, 80% of patients who just came in for an upper GI peak with endoscopy for dyspepsia, 80% of them had HP infection. So it's a very common cause of problems. How do you make the diagnosis? Well, you have to go in there. You have to look. There's no real test that you can do. Well, there is. You can if you've had it before, you can check for you check ammonia levels. There's a urea breath test you can check for, but we won't. That's getting too far into the weeds. So basically, you have to look for the presence of HP via a biopsy of the stomach, of the pyloric region. There will be no destruction of the pyloric glands in biopsy or any other glands. In fact, the G cells, they might be hypertrophic. I could have added that in there. G cells could be hypertrophic. Same with the ECL cells. Same with the parietal cells. They might actually start getting hypertrophy. But again, this is more the acute phase, so you're probably not going to see anything. There will be an inflammation, neutrophil heavy inflammation of the mucosa in the antral region as well. Histologists can see. So what's the deal? Why do we have, remember we said the patient is spitting up blood, hematemesis, and blood's coming out the other end, melena. Why do they have GERD symptoms? So they obviously must be over-secreting acid. So what's the deal? Why are they over-secreting acid? Well, here's the deal. It's believed that the HP and its associated inflammation that it stimulates, it irritates the antral G cells, not to destroy them, but to make them upset. And I said when cells get upset, they can do two things. They can stop releasing juice or they can over-release juice. And in this case, they get mad and crank out tons of the hormone gastrin, which we talked about already. So that leads to too much gastrin in the blood. That's hypergastrinemia. If you have too much gastrin in the blood, well, gastrin's going to do its thing. It's going to hit the ECL cells, bind to the ECL cells, which causes the production of histamine. Histamine's going to bind to the parietal cells, and you're going to crank out acid uncontrolled. There's no way to shut this off. It doesn't, somatostatin can't shut this down. So these patients will have hyperchlorhydria. That's too much hydrochloric acid. It's called hyperchlorhydria. All right, remember this. HP causes an inflammation in the pyloric region where these G cells, here's a fundic gland. The G cells live in the, or I'm sorry, it's a pyloric gland, and the G cells live in the pyloric gland. Stimulates the G cell secretes gastrin into the bloodstream, and gastrin hits its targets, hits ECL cells. It also binds to CCK2 receptors on parietal cells. So both of these mechanisms, it double stimulates the parietal cell to way over-secrete acid. And then you start burning holes in your stomach and burning holes in your duodenum and burning holes in your esophagus because of all this acid. Got it? All right, so in addition to PUD, peptic ulcer disease, and peptic ulcer, did we talk about that? Yeah, we will if we haven't. I think we did already, actually. Yeah, Yeah, I think we did. I can't remember. Now we'll talk about it, but it's peptic ulcer disease. Those are ulcers in the stomach or the duodenum. Duodenum, duodenum, tomatoes. So yeah, that's what peptic ulcer disease. And normally it's more that if you're going to have an ulcer, it's more likely it will be in the duodenum. It also gets GERD, anything with acid. So in addition to that, it does inflame the duodenum, as we said, and it can cause duodenal metaplasia, which can morph into dysplasia, which can morph into cancer. So people can, with nonatrophic gastritis, they can start to develop duodenal cancer, which is a little strange. The duodenal bulb is particularly susceptible because that's what gets bathed. That's the first part of the intestine, small bowel, that's exposed to acid coming out of the stomach. Sometimes some pathologists say that it's been gastrinized from chronic acid exposure. So just like the esophagus can get intestinalized from chronic acid exposure, the duodenum can get gastrinized. What does that mean? That's my word, but it's true. It can develop stomach tissue, including pyloric glands and including fundic glands, and it can even start secreting acid. And if your intestine gets gastrinized, an HP infection can move out of your stomach and actually move in to the duodenum, which is crazy, but it can. And this, of course, leads to severe ulcers in the duodenum. All this extra acid, especially if you have fundic glands producing with real parietal cells in them, in your small bowel, in your duodenum, cranking out acid. Your duodenum is not made to have acids being secreted out of that. There is an intestinal mucosal barrier, but it's not nearly as strong as the gastric intestine or the gastric mucosal barrier. All right. So what do you do for treatment here? Well, you kill the bug. And so you should do what's called a double antibiotic therapy. And it's not, I've went through it before, it's not fun. It causes diarrhea, and it was a rough couple weeks. But it did get rid of my HP. So a double antibiotic therapy, I cut all the details out because that's too far into the weeds. You can Google it. But in the meantime, because your gastrin is being way too high, or gastrin is being cranked out by the stimulated or inflamed G cells, you got to fight acid. So proton pump inhibitors, H2 blockers to combat the hyperchlorhydria. You have to do endoscopic monitoring to make sure no cancer has come up there. You can take painkillers like acetaminophen. You don't want to take aspirin though, right? Or NSAIDs, or like Advil or Nuprin or Aleve, or nothing like that, right? Because we know that decreases the strength of the gastric mucosal barrier and will lead to ulcers in and of itself. So if your stomach is already upset, you never want to take Advil, things like that. Acetaminophen is the way to go for pain. Fun facts, about 25% of patients, their dyspepsia doesn't stop after the HP is killed off. My GI doc, actually, we talked about this a little bit. How once you've had an infection and inflammation, it's generated pain, and you get rid of the culprit, the bug, it can go on for months, even a year, even years after the HP's been killed off, because your nervous system has been sensitized to feeling pain. Just like practice makes perfect, right? If you practice feeling pain over and over and over again, your nervous system gets really good at feeling that pain. And so when you take away the pain generator, well, it takes a long time for that mechanism to stop, because it kind of goes by itself. And on the other hand, in about 10% of the cases, now this research isn't the greatest, but there are some papers that have found that even if you don't do anything, the HP can sometimes mysteriously just disappear by itself. And that's been reported in up to 10% of the cases, although it takes a couple years for that to happen. All right, so that's the end of the non-atrophic gastritis. Pretty straightforward, HP infection of the antrum. Now let's talk about atrophic gastritis. So there's two types of categories here. There's autoimmune atrophic gastritis, and there's multifocal atrophic gastritis. So let's do the autoimmune first. So yep, this is the second main category of gastritis. There's two subdivisions under this category. There's autoimmune and multifocal. And let's talk about the autoimmune. Autoimmune atrophic gastritis, another cluster F. Ridiculous, absolutely ridiculous, all you pathology, pathology authors out there. Come on. How do you expect a student to know this stuff? So Robbins calls it autoimmune chronic atrophic gastritis. Okay, I'll buy that. Yamada calls it autoimmune gastritis. Diffuse atrophic gastritis, in the same couple pages he changes the name to diffuse atrophic gastritis, so that's not a great one, but who knows. Chronic atrophic gastritis, diffuse atrophic gastritis, Robbins is all over the place. Autoimmune metaplastic atrophic gastritis, that's what AMAG is, what Sleisenger calls it. And the Merck manual, another board book, is in the ring here, kind of calls it. But the key is look for the word autoimmune. Some call it type A. Remember we had non-atrophic gastritis, which was type B for bug. This is type A for autoimmune chronic gastritis as well. Now, if I'm writing a board question and I have open latitude, I mean, why tell you what the cause is, right? Because autoimmune gastritis, you know it's an autoimmune attack. Call it either type A gastritis, or how about this one? They use the word corporal, some authors. Diffuse corporal gastritis, diffuse corporal atrophic gastritis, body predominant gastritis. This one affects the body of the stomach. Corpus predominant. Corpus means body. So this one actually spares the antrum. The antrum is kind of already burned out, and the HP goes on and to other land. All right, but enough about that. Because for my test, I will most likely call it autoimmune atrophic gastritis. But you better know the ones in red, type A. You should know diffuse corporal as well. I won't call it pernicious anemia. That's too easy. So let's talk about it. Subcategory of the Sydney atrophic gastritis. We've already studied this before, because right, we talked about pernicious anemia in depth, and that's just the same thing. It's an autoimmune attack against the fundic region of the body. We looked at the different autoantibodies, and it destroys parietal cells usually. Remember, the type 3 autoantibody destroys it's against the proton pumps themselves. And yeah, patient symptoms, they're going to have upset tummy again. They're going to have dyspepsia. But because proton pumps are destroyed, here's the testable question, right? They're not going to have trouble with GERD. They're not going to have trouble with PUD either because the proton pumps are destroyed. So therefore, no GERD, no peptic ulcer disease. So that's a huge difference between the non-atrophic and the atrophic gastritis. Got it? How do you think the gastrin levels will be? Let's see, the gastrin levels were elevated in non-atrophic gastritis because the HP was irritating G cells. Well, now gastrin levels are also going to be increased because we don't have any hydrogen ions, so there's nothing to turn them off. So in both atrophic and non-atrophic, their gastrin levels are going to be elevated. Leads to chronic immune-related inflammation. Yeah, we've talked about it. Your own body doesn't like the looks of parietal cells for whatever reason, and attacks them. And it spares the antrum of the stomach with this type. So antrum is spared. So these are the patients that develop type A pernicious anemia, which is autoimmune related. They're the ones that have those type 3 autoantibodies as well. Fun facts, it's less than 10% of chronic gastritis, so it's kind of rare. HP-associated non-atrophic gastritis is way more common. It tends to hit Caucasians more, especially with Scandinavian descent. And there is genes. If mom and dad have had this, your chances are higher. It's autosomal recessive trait, it's believed. And about 90% have those type 3 autoantibodies that we've already talked about before. So, and those are the autoantibodies that attack specifically the proton pumps in parietal cells. What's the sequelae of the autoimmune attack? Well, the parietal cell gets destroyed. And collateral damage, the inflammation caused by the autoimmune attack, knocks out the chief cells. So in fact, you basically lose your entire fundic gland, a.k.a. accentic gland, and there goes your hipster, right? There goes your no hydrochloric acid, no intrinsic factor, no pepsinogen with this type of deal. Therefore, clinically, how will you present? Or if you take stomach juice, what will that look? Take blood work, what will that all look like? Well, you have hypochlorhydria, meaning not enough acid, or achlorhydria, no acid. You'll have hypergastrinemia, just like non-atrophic gastritis. I explained that. But if you don't have intrinsic factor, you can't reabsorb vitamin B12. So after about a year or so, after your liver stores run out, you're going to develop vitamin B12 deficiency, which is a form of, like folic acid deficiency, it's a form of megaloblastic anemia, and we talked all about that. Histological signs. So if gastrin is floating around, ECL cells are working like crazy. And this is true of non-atrophic gastritis as well. So ECLs will be hyperplastic. There'll be too many of them. They'll, from exercising, they get big and they multiply. And same with the parietal cells as well. They get hit and stimulated by histamine and by gastrin, but they can't do anything because they're broken. So they might not, they could still get big though, but they don't work. And the G cells will be hyperplastic as well. Now there are associations because what's the rule of autoimmune disease? If you have one, you could well have another. And so type A pernicious anemia is basically guaranteed. Iron deficiency anemia is common. Psoriasis or psoriatic arthritis, common. That's autoimmune. Hypothyroidism. That's low thyroid. Hypothyroidism, a.k.a. Hashimoto's disease, autoimmune. Type 1 diabetes, autoimmune. Sjogren's disease, autoimmune. Rosacea is a mystery, but think it's autoimmune disease. We'll talk about that. Actually, I took that out of dermatology, but I have that on YouTube. We need to expand that dermatology class. Don't get me started on that. Risk of cancer. Yes, there is a threefold increase for the risk of cancer from this condition. Not Barrett's esophagus. I've asked that on the test before and faked people out. Remember, there's decreased acid in this atrophic gastritis. So you're not going to get a Barrett's esophagus, but you will get stomach cancer from the inflammation caused by the autoimmune attack on parietal cells. And specifically, you'll get the inflammation in the fundic region of the stomach, which is, remember, the fundic, histological fundic region of the stomach is the anatomical body, and the anatomical fundus and the anatomical cardiac region all combined into one. How do you treat this? Well, you got to give them injections of vitamin B12. You monitor vitamin B12 and give them injections as needed. Immunosuppressants to slow things down, slow down the aggressiveness of the autoimmune attack. Watch for iron deficiency anemia. They might need ferrous sulfate, which is how you fight that. And then again, pain medication. If they have an upset stomach, give them Tylenol, not any of the COX-1 or even COX-2 inhibitors. Fun facts. Yep, we've already said all this. So this autoimmune atrophic gastritis, these people are protected from PUD, GERD, Barrett's esophagus, and esophageal carcinoma. Already said that. Endoscopic evaluation, what if you go down there and look around? Well, this is a pretty devastating attack, unlike nonatrophic gastritis, which doesn't do too much damage. Fundic region may be pretty ripped up from the autoimmune attack, and so you can get a severe atrophy of the rugae, which are, the body of the stomach is all rugae. That's considered part of the fundic region. It can be destroyed, so you get loss of rugae. There's a nice stomach with lots of rugae. Here's someone with autoimmune gastritis here. They're gone, right? They're just completely destroyed. Okay, now we have multifocal atrophic gastritis. So this is the other type of atrophic gastritis. Again, same crazy mess. Sometimes they call it MAG for multifocal atrophic gastritis, environmental metaplastic atrophic gastritis, type AB chronic gastritis. It's not quite as bad as the other ones. H. pylori associated. See, here's the problem, Rubins and Robbins. Some authors call this HP associated atrophic gastritis. So you should keep HP because that can also cause non-atrophic gastritis. All right. Sometimes it's called atrophic pangastritis. Odze calls it that, and that's a smart one because this one of pangastritis, this is an HP infection. Part of it's believed to be anyway. It might be from environmental factors. We're not 100% sure, but we know HP is one cause of this. But a pan means the entire stomach is affected. So it is, again, it's the second type of atrophic gastritis. Autoimmune was the first. There are two possible causes of multifocal atrophic gastritis. Actually, you know what? We went too far. I think I'm into part 2 because this was kind of a short lecture, but well, let's keep going. I'm on a roll. So there's two possible causes. 75% of the time, it's from a chronic HP infection that started as a non-atrophic gastritis, and it progressed over decades, and it's taken out the entire stomach. Then in 25% of the people, they don't have an HP infection, and we don't know what causes it. It's believed that maybe some environmental factor has gotten into the stomach. Maybe it's smoking, chewing tobacco, we're not sure, but whatever it is, it's destroying the entire stomach. So unlike autoimmune atrophic gastritis, which spared, remember that one was the autoimmune attack against the fundic region of the stomach. So this one takes over the entire stomach. So this is considered a pangastritis. So everything gets destroyed. So this is the really bad one. When you think of multifocal atrophic gastritis, think stomach cancer, because this is the big one that increases the risks of stomach cancer. By the way, Rubins says the etiology of multifocal gastritis, atrophic gastritis unknown. That's absolutely not true, Rubins. Rubins is, that's my least favorite of the board. If I had to choose one, I'd always choose Robbins, because Rubin says things like that, and I mean, we've known for over 20 years that HP is the cause of multifocal atrophic gastritis in certain cases. It's this part that we don't know for sure what causes it. Yep. So in many cases, this multifocal, especially if it's HP related, it's believed to just be a progression from non-atrophic gastritis. Kind of said that already. It's the untreated HP infection that maybe the person just doesn't feel that much, and it just takes over the entire stomach. Or whatever it is, the entire multifocal means the entire stomach is involved. How do you know if you have an HP infection? Well, that's a good kind of a general question. There is a blood test that can detect autoantibodies for this. But that if you've had HP and it died off or you killed it off, those antibodies will always be present. It's called the IgG, anti-H. pylori autoantibody. So you can test for it if this is your first time. But again, the problem won't tell you. Maybe you had this 20 years ago and the HP died off on its own. So you can't tell if it's acute or an old infection is the problem with that. Because once you've had HP, that IgG will always be elevated. Stomach biopsy is the way to go because you can physically see the little bugs running around. Here is the urea breath test I talked about. So that's what I had to do because I had HP a long time ago. Got rid of it, and I had a negative urea breath test. But if I ever thought I developed it again, I know I'm going to have autoantibodies. So the only way to make the diagnosis now is just to go down there with a scope and see what's going on. Or I could use this urea breath test again to see. And I took all these slides out because that's Dr. Dole's world, but I have YouTube videos on HP. And that a little ammonia cloud that circles it, right? It has an ammonia cloud like that pig pen on the Snoopy characters, Peanuts characters. It has a cloud of ammonia around it. That's why it can stay in the acidic environment of your stomach because of that cloud. But they can test for that. They can make you drink liquids that kills HP and releases that ammonia cloud from it. And they can detect that in your breath. So I've had that. Is it a fun test? Nah, it's not that bad. It takes some time though. I was in there like over an hour to do it. But yeah, that's the story with that. And yeah, so it's a pan-gastritis. It's not in the long run. It's not uncommon for HP to kill so much stomach tissue off that it has nowhere to live anymore. Because HP needs gastric glands, fundus glands, gastric glands. Remember, that's all the glands, but it needs glands to live in, and it needs acid. So if it kills all the fundus glands off and you don't make acid, it can't live. And then from the chronic inflammation, you can become metaplastic, the stomach tissue, and then it can become dysplastic and then cancerous. Here's a histological sampling of a patient with an HP infection and all those little black dots. This is the mucosal layer here. These are simple columnar cells. If you look real close, you can see the cell nuclei. All those black dots, H. pylori. Area 51. Is it always HP? No, we said sometimes in 25% of the people we don't know what the cause is. And yeah, so it's maybe some, as I said, some environmental toxin. We really don't know. Is it aliens have flown into your stomach? Probably not that. But it is a mystery. Special forms of gastritis. So, yeah, maybe we'll do this whole thing. I got 20 more slides. Let's just knock this off in one PowerPoint. Special forms of gastritis. So, this is you drink the antifreeze and you burn a hole in your stomach. This is it. You drink 10 shots of moonshine and you wake up the next day and your stomach is killing you. You might even be vomiting up a little blood from that. These are gastritises. They're special forms. These are called chemical gastritises. So these are the ones that don't fit in the other category. So yeah, the players of the special forms of gastritis are chemical gastritis. That's the only one we're going to talk about. I took all these other slides out because it's just getting too crazy. But radiation, so you have chemotherapy, you get zapped by radiation for a stomach tumor. It can cause a gastritis. The radiation can inflame things. A lymphocyte heavy gastritis, some types of viruses and bacteria invoke a lymphocyte heavy inflammation, and that can be very nauseating, very upsetting. And eosinophilic, non-infectious granulomatous, other ones. Yeah, we're just going to worry about the chemical ones. So let's talk about special forms. Let's just talk about chemical gastritis. And oh, here comes the shame again. So, but a really good, a strong A.k.a. for this is called reactive gastropathy. So Sleisenger, one of my favorite GI path authors, uses that, and other authors. I think that's a medical board book, Sleisenger. But they call it reactive gastropathy, so watch out for that. Some call it reactive gastritis, which isn't really the greatest name. Mayo Clinic. Acute erosive gastropathy, acute hemorrhagic gastropathy, acute gastritis, etc. Rubin's calls it alcohol-induced gastropathy or chronic gastritis. Or Rubin's just calls it chronic gastritis, which is, these are all chronic. This is the main subject we're talking about, the chronic gastritises. We're talking about the 3 subcategories under chronic gastritis. Remember those? 3 categories of the chronic gastritises were non-atrophic gastritis, atrophic gastritis, and other special forms. So Robbins calls it chronic gastritis. I don't know if he's not he doesn't read the literature or read the other books, or this is just unexcusable. Shame. Anyway, that's enough of that. Some call it type C gastritis as well. I like reactive gastropathy. I probably won't call it chemical gastritis, but I do like, it's such a common AK, I do like reactive gastropathy. So this is where the traditional real acute gastritises were placed into the Sydney system under this chemicals. So these include alcohol, and I'm not talking a glass of wine or a couple beers, I'm talking 10 shots of moonshine, a case of beer, things like that. NSAID injury would cause a chemical gastritis. Bile reflux injury can cause a chemical gastritis. And this is where the antifreeze comes in, accidental poisonings. So all of these things knock out that gastric mucosal barrier, right? These are all caused because you have a force field around your gastric mucosa, right? It's called the GMB, the gastric mucosal barrier. We've talked about that in PGE, how important that is for making that. But they all of these chemicals just walk right through the protective gastric mucosal barrier like it's not even there. And they just rip up and kill the mucosal layer and even get into the submucosal layer. So you can get rapid bleeding with this real fast. Hematemesis, hemoptysis, coughing up blood, spitting up blood, throwing up blood. Coffee ground vomitus is really a subcategory of hematemesis because it's still throwing up coffee grounds. Do you guys remember what that means? What do you know if somebody throws up coffee grounds? I showed you pictures of that. Well, that means the blood has been sitting in the stomach for a long time. It's not an acute bleed, it's a slow leak, and it's been digested. So it has a coffee color to it. But yeah, so gastric mucosal barrier is overthrown by these things. And it typically does not even cause an inflammation. It just flat out physically destroys the cells. And that's why it's terrible for everybody to be calling it, in my opinion, a gastritis, because that's inflammation. And oftentimes there is no inflammation. There's just a hole in the stomach when they go down and look in the ER. So, yeah, chemical injury destroys the mucus, submucosal. So very few neutrophils around. So yeah, this is why it's better to call this a gastritis. This whole section should be called a gastropathy, not a gastritis. Don't forget that A.k.a. reactive gastropathy. Don't forget it. What's the endoscopic appearance look like? Well, you've damaged the stomach. You went down there and punched it, or ripped it up, physically ripped it up. So you're going to have these red streaks on endoscopic evaluation. You're going to see signs of hemorrhage, erosions, maybe ulcers may be there already. Maybe a lot of blood around the ulcers. That's where the acute hemorrhagic gastropathy comes from. Here's a picture of someone with reactive gastropathy. And that stomach doesn't look like a happy stomach, does it? It's ripped to pieces. What are the causes again? Talked about them already. Aspirin, NSAIDs, super strong, high-proof ethanol like moonshine. Yep. So ethanol. That's alcohol is poison, right? It's like acid. They're using ethanol now to inject inside the disc, and it will destroy and dissolve the nucleus pulposus. And they're using that to try to contain disc herniations back inside the disc by removing volume. They used to use papaya enzyme, but that got out and caused paralysis. So now they're messing around with ethanol. If you really want to mess up your stomach, combine NSAIDs and alcohol together, and your stomach is pretty much doomed from that. Sorry about that. There was no gross picture warning, but the poor person here severely, severely burned. How does she have stomach problems? Why is she started on proton pump inhibitors? Because she's going to be in the hospital a long time if she's going to make it. They start her on PPIs. Why? How can she get a messed up stomach? How can she get stomach ulcers? In fact, these are called curling ulcers that occur in her tummy. I mean, that's the least of her worries, PPIs, but they do. They'll start her right on PPIs. Well, what happens in burn victims? Is she going to swell? Oh yeah, remember we've seen pictures of that. Her whole body's going to swell. So the interstitium everywhere in the body is going to be overfilled with interstitial fluid that can't be drained off. So that excess interstitial fluid below the mucosal layer, right? The stomach has simple columnar cells. It has an interstitium underneath it. It's going to be flooded with molecules, and you can't get blood, or you can't get the nutrients to feed the lining of the stomach anymore. And those cells start to die. And without those cells, there's no gastric mucosal barrier. So she's going to completely lose her gastric mucosal barrier, and the acid will rip holes in her stomach if they didn't start PPIs. Even if they start PPIs, she can still develop ulcers. So it's a really bad problem. So yeah, could a burn victim suffer a reactive gastropathy? Yes, they can. How in the world could that be? Albumin is lost. Albumin is lost through the damaged skin. So all the epidermis and dermis is gone here. So all the capillaries are leaking albumin. So her whole body has no albumin. And therefore the sucking power is lost. Plus just the physical damage of the microcirculation will let blood fluid dump out, not even withstanding albumin. So bottom line, the mucosal layer of the stomach swells just like the rest of her body will. Right, everything I said. So interstitium becomes very congested and the nutrients can't swim to feed the mucosal cells and the mucosal cells die. Right, and there goes your gastrommucosal barrier. All right, so it's like if this is your, this is a hungry cell that's protecting your stomach. Now we have all these fish in the way. Normally there's very few fish here. Glucose and oxygen can swim out of the microcirculation, out of the capillary, go feed the cell. But it can't get through because there's so many darn fish here. It's kind of like the Bay Area traffic, right? It used to be nothing like it is now. Now it takes forever to get to work because there's too many cars, too many people in California, and they didn't fix the roads to accommodate all those people. Don't get me started. I'm on a roll today, aren't I? Yeah, so there's nothing to stop everything I've said. And these again, they're called curling ulcers. They're just stomach ulcers or duodenal ulcers, but if they occur in a burn victim, they have a special name. So make sure there's a high yield board in my test. You got to know what a curling ulcer is, and you got to know what causes it, how that happens. There's a curling ulcer in this patient right there. How do NSAIDs damage the gastrommucosal barrier? We've already talked about this. I probably could have taken these out. But remember, NSAIDs knock out PGE2, prostaglandin E2, and, well, they don't knock out PGE2. They knock out COX-1. COX-1 is the one who makes PGE2. COX-2 can make it as well, but you have to have PGE2 in order to make mucus, and in order to stimulate the ECL cells or to inhibit ECL cells to decrease acid production. So we know that story already. Ulcers and even perforations can easily, yes, they can. Okay, there are some other substances that can cause reactive gastropathy. Heavy metal poisoning, so mercury, selenium, inhaled ketamine, special K, I don't know what they call it. That's what they used to call it back in my college days. Not that I've ever done this crazy stuff. I'd never be so stupid to do that. But interestingly, they've taken special K, Stanford has, and some people are resistant to depression medication, and they are using a kind of a weakened form of ketamine to help, and it's very promising for people with severe depression. So, and yeah, it's a very, very powerful anesthetic. Okay, what else can cause reactive gastropathy? How about bile reflux? Yeah, so bile, if your pyloric sphincter is weak and fails, you can get that bile juice going up, backwashing into your stomach. And that's not good. Bile will rip through your gastrommucosal barrier like nothing, and it'll definitely inflame your stomach. So that's also one of the reactive gastropathies is bile juice. Very difficult to tell apart from alcohol and NSAID damage because there's usually no inflammatory cells, right? Again, you guys, don't call it itis because there's no inflammation. Better to call this chemical gastropathy. Let's see. Yep, talked about that. What are some risk factors for bile reflux? Well, actually, one of my problems is I have a very slow, I battle GERD, and I've talked to the Stanford doc, one procedure is to loosen the pyloric sphincter to help clear the stomach. But unfortunately, about 20% of those people, and who've had other tummy tuck and other gastric procedures, especially the loosening procedure of the pyloric sphincter, it becomes too lax, and then you get a problem with bile reflux, and that can chronically irritate your stomach as well. Chronic respiratory disease, if you're coughing all the time, you always have increased interabdominal pressure, and that can not only encourage acid to go up into the esophagus, but it can also encourage bile to go up into the stomach. And anything that increases intra-abdominal pressure, like weightlifting, obesity, and things like that. What are the symptoms? The same old symptoms. Dyspepsia, hemoptysis, hematemesis, melena, the same symptoms. Interesting, one side note with bile reflux is if you do have this, you're not going to have HP around because it will kill the HP. HP can't stand bile. So at least that's one good thing. What's the treatment? Well, if possible, figure out the cause and stop the cause, but turn off acids because you don't have much of a gastric mucosal barrier. Has been damaged and you have raw tissue in the stomach. You can't be making acid. So modified diet. Turn off the acid with proton pump inhibitors. Modify the diet. We've talked about bland diet before. No protein, nothing that would stimulate acid production. Small meals. No spicy foods, alcohol, red sauce, which is acidic. And then the last fix is to go tighten the pyloric sphincter, but that could cause delayed gastric emptying and increase the chance for GERD. So, all right, we got through part 1 and part 2, so this was a little short lecture, but that's good because you got the test next week. And see y'all later. We'll keep our fingers crossed to see if this one actually shows up on Brightspace.